Hi, everyone. As you all know, I'm very, very excitable, very, very easily excitable. But today I'm especially excited because I think it represents a lot of generational bridges. So I'm not in actual life very old, but in terms of CP Solver's life, very, very old. Um, and I feel like I'm bridging two generations here. The first, of course, and the most ancient is the generation of current CP Solver's interns. And I'm very excited that you'll be hearing two of their voices very, very frequently, Maddie and Tansu. I'll tell you more about them in a sec. But helping make this happen is the most recent generation of CP Solvers Academy members, including our most recent Academy member. And so to celebrate them first, I'd love to hand the mic to Eugene, who is scribing for the first time, and maybe tell us a little bit about yourself, Eugene.
Hello, everyone. So I am Eugene from Ghana. Been joining CP Solvers for about 4 or 5 months now, and I'm happy to scribe today. I actually did teaching points yesterday and was fun, so I decided to do scribing today.
Amazing. Well, you're accompanied by a seasoned Thursday 6 a.m. Pacific scribe. Noreen, how are you doing?
I'm good, Rabih. How are you?
I'm doing very well. Thank you for asking. How's your day been so far?
It's been going good. I'm just supporting today. Eugene's the main star.
Nice. I love it. I love it. Well, thanks for being back up. It's great to see you here. I also see Julia's in her traditional 6 a.m. Pacific Thursday position and teaching points outside. We're all just very routine oriented, huh, Julia?
Yeah, it is the best to be outside. It is the best to see you every single Thursday, and it is the best to see our community grow. So, very happy to introduce and say hi to Jürgen today. And I've actually been to Ghana for an internship 2 years ago, and it was such an amazing time. So, yeah, I've loved to chat a little bit with you later on about it.
Yeah, sure. I mean, where in Ghana, if you don't mind?
In Accra.
Okay. Yeah, we can talk.
Malibu. Yeah.
Okay.
He seems impressed, Julia. That's awesome. Uh, um, and now the now, as if I'm some sort of boxing announcer. I'm really excited to tell you that the one and only Maddie is presenting you a case. Let me hand the mic to Maddie before we introduce our case discussant.
Yeah, hello, everyone. I'm just so happy to be here whenever I'm on a kind of a busy month of rotations and I don't get to tune into VMR as much. It's just like such a treat to get to see all of you. And Eugene, just wanted to officially welcome you to the Academy. I hadn't had a chance to, officially welcome you. So welcome. Really happy to have you in the Academy. And yeah, I'm so excited to present this case. I saw it last week on my rotation. And Tansu, it's so good to see you. And I hope the end of intern year is going smoothly.
Yeah, we're here to really, really celebrate and honor Tansu. She's been working so hard intern year. And if you don't know, and her name is not familiar to you, all you have to do is just rewind the clock a year and see that she was essentially a pillar of VMR. And she remains very, very active. One of the pillars of the case review committee is um, it's a real delight to welcome her back and co-discuss with you, Tansu. And hopefully this will be the spark of many, many more in the future. But I'm glad we're making it happen intern year. I'll hand the mic to you to maybe update folks on how life is treating you, and then we'll jump right in.
Sure. Hello, everyone. So excited to be here. It has been a while, definitely. Intern year has been a little tough at times, and the schedule has also been a little rough. 6 weeks of inpatient and 2 weeks of outpatient blocks. I'm now in my outpatient block for 2 weeks, and I took the opportunity to take this day off so that I can be together with you in this hot seat. I'm a little nervous because it had been a while since I didn't do this, but I trust Rabih and Maddie. I think it will be great.
And we're gonna have so much fun. I don't want to delay it any further. Well, Maddie, why don't you take it away?
All right. Okay, so this is a case, as I mentioned, as I saw last week. So it's a case of a 67-year-old woman, and she was brought in by EMS from an outside emergency department because of chest pain. And so she presented around 2 p.m. in the afternoon. And when we asked kind of when did this pain start, she said that the pain started the day before in the morning at 8 a.m. So it had been about like 30 hours since the initial onset of the chest pain. And when asked about kind of the circumstances of what she was doing when this came on, so she was standing in a chair in her kitchen trying to grab something from kind of a high shelf when she developed this sudden onset severe chest pain. The intensity was rated as a 7 out of 10. She said it was located in kind of the substernal area. And she said it kind of radiated up her chest, felt like this kind of flushing sensation up her chest. And she also felt this feeling of numbness in her right arm. And I'll give you a little bit more history, but in the next LCOP, but I'll just pause there to get any initial thoughts.
Oh, what a start, Maddie. Tansu, I have no guiding questions to ask because I imagine you've been in this circumstance before. So I'm really curious what thoughts are flowing in your mind.
Yes, it does look like a very classical presentation of a very deadly condition, ACS. This is the first thing that comes to my mind and what I'm worried about the most that I should be ruling out. Of course, there can be mimics of ACS too, but I'll just summarize what I heard from Maddie and what features of this presentation worries me the most and makes me think that this could be more ACS than anything else. So the age of the patient is 67. And she had this sudden onset chest pain. And it sounds like it didn't start on exertion, like florid exertion. Maybe she was exerting herself a little, standing up on her chair. And it was sudden onset in the substernum. And it was accompanied by like autonomic symptoms of flushing. And there was a little bit of a right arm numbness too. So the laterality of the arm, right or left, doesn't make a difference that much for me, but it's radiating somewhere and it's causing a neurologic symptom, neurologic deficit in one arm. Flushing is definitely something that I would expect accompanying an ACS type of situation. It's kind of similar to diaphoresis for me. So I'm definitely thinking ACS here, and I would like to see an EKG, ASAP, and troponin at time point 0. It had been a while since she had this pain now, about 30 hours. So this could be a delayed presentation of ACS. But maybe we have more information from the first, the outside hospital the patient was transferred from. Maybe if we can get, if they got the EKG there, if they got a troponin there, if we can have access to that information, that would be great here. And after ruling out ACS, I'd be thinking about other differentials too. And there I'm thinking about our 4+2+2 schema. So 4 conditions related to cardiac problems, and then 2 conditions related to pulmonary and 2 esophageal disorders that can cause a kind of a acute onset chest pain. And in the cardiac sphere, I'm thinking about acute coronary syndrome. As I said, this is the first thing to come to mind, and aortic dissection would be the second one. I would expect a radiating pain to the back if I'm considering the idea of aortic dissection. And then another thought would be cardiac tamponade, which I'm not seeing that sort of a flavor here. But it would be worth getting an echocardiography anyway, even after ACS, to see if there's a wall motion abnormality. So that would be also showing me if there's a tamponade or not. And then the fourth differential in the heart bucket would be Takotsubo cardiomyopathy. And Takotsubo cardiomyopathy, I actually have seen this twice in the intern year. It can present very similarly to ACS. And echocardiography, first coronary angiography to rule out any occlusion in the coronary vessels, and then the echocardiography would be the way to go to investigate Takotsubo cardiomyopathy. And then in the lung bucket, I'm thinking about definitely PE. It can be a great mimic of acute coronary syndrome. And in this patient, well, I would investigate that later, definitely, not right away. And then pneumothorax would be another differential in the pulmonary bucket, but I'm not hearing anything about difficulty breathing, any respiratory symptoms yet. So I'm also holding that on the side. maybe further workup. If we rule out ACS, then I would entertain investigating that. And then two, in the esophageal bucket, I'm thinking about either an esophageal rupture that can cause severe chest pain, or esophageal infections that can also cause severe chest pain. But I'm also not hearing an itis, like esophagitis or esophageal infection flavor here yet either. So ACS, ACS, ACS. I'll rule that out first. What do you think, Rabih?
That was such a, I mean, it's incredible both how much you have carried with you into intern year with such a comprehensive approach to chest pain, but also the power of, the time that you've invested, 6 weeks inpatient, 2 weeks outpatient. I can hear that. And in that, I think when you're a junior, you just lay out the whole schema, but here you've been conditioned to really incorporate base rate so powerfully, so in how you started your analysis and how you ended at ACS, ACS, ACS. So not only are you well informed about what it could be, but you're also proportionally informed about what it's likely to be at the same time. And I think to help us zoom in on your considerations, I just emphasize what you said about the pillars of the diagnosis of ACS. You said, in addition to listening closely to the story, you want an EKG and troponin right away. And those are the three pillars that are immediately available to help you diagnose ACS: a classic story, a classic EKG, and a classic troponin. But you actually subtly also introduced the other three pillars that help you reinforce the main three pillars. And the three other pillars are prior history suggestive of coronary artery disease. So it's much more likely that somebody has ACS when you know they have CAD. The other pillar is using an echo to detect focal wall motion changes in a vascular territory. And the third, i.e. the sixth in some ways, is the most subconscious, but it's really important to bring it to light, which is ruling out an alternative cause. So if I give you a classic story, a classic EKG, a classic troponin, no alternate diagnosis, a history of CAD, and focal wall motion changes in a vascular territory, I've left nothing on the table for you to do a coronary angiography. And so I think it's really important to outline all these 6 tools, because in some cases you only need one. EKG showing ST elevations with reciprocal depressions is all I need to take a patient to a cath lab. A classic story, even with a negative EKG and a negative troponin, sometimes is all I need to take a patient to the cath lab. I'm talking as if I'm the one to take the patient to the cath lab. It's all I need to call cardiology to take the patient to the cath lab. So these are the 6 pillars, Tansu, and we're gonna, maybe you and I can try to deliberately plug in each of them. And you mentioned, so far we have the story, we don't have anything else, and we'll see how well and how strong the case is for ACS with more and more information. But those are the six aspects, the 3 of which we get immediately: story, EKG, troponin, 5-10 minutes after. And depending on where the patient's plugged in and how powerful our resources are with echo, we may have others or not. But I wanted to latch on to one thing that you said, which I think a lot of people find confusing, which is the concept of chest pain with exertion and ACS. So acute coronary syndrome, by definition, requires the patient to have severe chest pain at rest. So many people with chest pain at rest are no longer exerting themselves. So the value of asking them if they have exertional chest pain is diminished, because they would look at you funny saying, why would I even consider walking around? The truth is, if you get lucky and the patient says, oh, the pain's mild and I walk around and it's not worse, that's very, very helpful. It makes it less likely to be cardiac chest pain. The way you want to ask the patient if they have chest pain on exertion is to ask them, before they had this pain at rest, do they have chest pain on exertion? Because what you're getting at is not ACS. You're getting at, do they have progressive CAD? So the best story for ACS is, oh gosh, all of a sudden, 11 a.m., I'm sitting in the kitchen, severe chest pain. Oh, I'm sorry, that sucks. Tell me about the day prior. When you were walking around the day prior, did you have any chest pain at all? Oh, I ran a marathon the day prior. They probably don't have flow limiting CAD, and they may have ACS from a coronary dissection or some non-plaque rupture ACS. But the probability of ACS plummets not to zero, but much lower if the patient had no flow limiting symptoms beforehand. So you want to be careful about when you ask the exertional. It's usually not helpful when they're uncomfortable. They're not going to walk around. But if you ask them to rewind the clock to before they had the chest pain at rest, to try to gauge, do they have an exertional component suggestive of CAD before this all started? So any thoughts or clarifications you want to make, Tansu? Questions about that concept? I just want to make sure it's clear to everybody.
Yeah, it makes sense. It makes sense. Of course, we have to assess what came before this index presentation that we are seeing in front of our eyes.
Alrighty, Maddie.
All right. Absolutely amazing discussion. All right, so to give you a little bit more history, so she said that, when it came on, this severe substernal 7 out of 10 chest pain, that actually lasted about an hour. And then it was mainly chest tightness that she reported. And so this was more of a 2 out of 10. And so she actually had some aspirin at home. So she took 4 baby aspirin throughout the day, and that mildly improved the pain, but she still had this kind of persistent chest tightness. She actually went to work that day. She went to sleep. The next morning, she went to work again. But then at work, she still had this persistent chest tightness, which is kind of what prompted her to go to this outside emergency department. In terms of review systems, I mentioned she had this kind of diaphoresis and kind of a flushing sensation when there was that acute onset pain. But she didn't have many other symptoms. So she didn't have any shortness of breath. She hadn't reported any leg swelling, no weight changes recently, no abdominal pain, nausea, vomiting, no fevers, chills, sick contacts, recent travel. Past medical history, so she has no prior cardiac history. She has a history of hypertension that she's on lisinopril for, hyperlipidemia that she's on atorvastatin for, and she has hypothyroidism and she's on levothyroxine. In terms of social history, she actually works at a wildlife refuge in Colorado. She does not report using tobacco or alcohol, and no other pertinent social history. Kind of, I guess, going back to kind of the question that Rabih posed when asked about if she had had this type of chest pain before and any kind of shortness of breath or chest pain with exertion, she said that this had not happened before and she usually does not have issues walking long distances. So I'm going to show you, so at the outside ED, they got an EKG. And I would love to show you that if you want to take a stab at seeing what stands out to you, and then I can share kind of what their thinking was. Can you all see this? Okay, I'll just give you a second to look at it and then share what they were.
Well, thank you, Maddie, for such like the information coming our way is really is right on cue. Thank you so much, Tansu. I'm sure you've been waiting for this moment where you get to dissect an EKG in front of a live audience as an intern. But what are your thoughts?
I was actually expecting that I'd be seeing an EKG. We always see an EKG. So I will try to walk us through, and Rabih, please fill in the blanks if I leave out anything. So first thing that I look at when I see an EKG is the axis. And for axis determination, I look at the most left-facing limb lead, which is 1, and AVF, which is the inferiorly facing lead. And I use the thumb up and thumb down method because that's the easiest to remember. So in lead 1, I'm seeing that the QRS complex is thumb up, and in the AVF, it's thumb down. So positive in 1 and negative in AVF is kind of, it's towards the left, but that can be either left axis deviation or it can still be normal axis. So I look at lead 2, which doesn't help me so much here because it's kind of unequal vocal. The R and S are equal distance. So the segments are equal. So I think this is likely normal axis. And then I look at the rate and rhythm. So for the rate determination, this looks pretty regular. The the QRS distances, the number of squares between R to R looks pretty equal to me. So I'm just taking the number of big boxes between the two R waves, which is 1, 2, 3, 4, 5, about 5 big boxes. And then I divide that by 300. So heart rate is about 60. And then I have to determine if this is sinus or non-sinus. And for the rhythm to be sinus, not only I have to have a P wave followed by a QRS, but I also have to have the P wave to have certain characteristics, one of which being it should be around 120 milliseconds. And it looks so in this case. And then I also want that to be upright in lead 2, which is also the case. The P wave is upright and it looks about, yeah, like around 120 milliseconds. So I think this is sinus rhythm. And then I start looking at the PR interval. I'm seeing the PR interval is supposed to be around 120 to 200 milliseconds, and which seems to be the case here. So around 3 to 5 small squares. It looks appropriate. And then I look at the QRS wave, and the QRS is supposed to be between 2.5 small squares, 2 to 2.5 small squares, 100 milliseconds or less is the appropriate QRS duration. And here it looks about 2 to 3 small squares. So this is also appropriate. And then I'm looking at the ST segments, which will be the key here in this case. And when I look at the ST segments, of course, it needs to be following a territorial pattern. And so I first look at the 2-3 AVF for inferior MIs. And here I'm not seeing an ST elevation. And what I mean by ST elevation, so basically it's ST segments elevation by 1 millimeter in every lead except for V1 and V2, because V1 and V2 are the closest to the chest wall. So our criteria is higher there. It needs to be higher than 2 small squares. And here in the 2-3 AVF, I'm not seeing an ST segment elevation, I think. And then I'm looking at the lateral leads. So that's a 1 AVL and V5 and V6. I'm also not seeing an ST segment elevation in those leads. And then I'm looking at the anterior leads. And I think we have an ST segment elevation in V2. We definitely have an ST segment elevation V3 and then V4 maybe. I think there might be an anterior infarct here. I hope I'm doing this right. So this is the way that I would go about it. And then the T waves look fine to me. I think there are a couple T wave inversions in some leads, like V1. I don't remember which leads. Is it okay to see the inverted T waves? But I think it's okay to see them in V1 and AVR, which seems to be the case here. So it's appropriate. And I think there might be an anterior infarct here with the ST segment elevation, V2, V3, maybe V4. What do you think, Rabih?
Absolutely outstanding. I have nothing to add to your analysis. I think you identified everything, including the ST elevations in the anterior leads. I think you'll notice that the V2 and ST elevation is much less prominent than the V3 ST elevation, but that's not correct, actually. In proportion to the size of the QRS, which is the standard, the V2 elevation is even more impressive than the V3 elevation because of how small the QRS is in V2. So both of these are significant ST elevations. And now part of what we have to do is to try to time the event. And so her history is one way we time the event of ACS. The other is by some subtle analysis of the EKG, i.e. the Q waves. So what do you think about Q waves in the anterior leads? Do you see them or are they absent?
Can we see the EKG one more time in the...
Yeah, if you click on Maddie's screen at the top of your Zoom link, you'll be able to see both Noreen and Maddie. Yeah.
Okay, so the Q waves, the Q waves are supposed to be 1/4 of the whole QRS complex. And here, I think we do have pathologic Q waves too, yes.
Yeah. So this suggests that her infarct is delayed. So there's two possibilities with this EKG alone, that she is an evolving anterior ST elevation MI and has just developed Q waves, or that she has an old MI, as evidenced by the Q waves, and her ST segments represent either a repolarization abnormality associated with an old MI or an LV aneurysm. So if you just look at this EKG alone, you know by the presence of her Q waves and the poor R wave progression that she has, i.e., that she does not have a dominant R wave until probably V5 or V6. It should be by V3 or V4. That she has an old anterior MI. Question is how old? And the history is helpful, but if you're using this EKG, you'll use the ST segment elevations to prioritize that it is hours or days old, but it is also possible that these ST segments represent repolarization abnormality from her Q wave, or that they represent the presence of an LV aneurysm as a sequelae of MI. So if you were seeing this EKG, Tansu, and that's all you had, do you think you would start treatment? And if so, what kind of treatment would you start for the patient?
I would definitely call cardiology first, activate the STEMI code, and then the patient already took 4 baby aspirins before coming to the hospital. So that's about 300 milligrams of aspirin, but I wouldn't rely on it necessarily. If I'm considering whether I should load the patient with aspirin or not, I would go ahead and do it. I wouldn't rely on what they did before the hospital. So, and then I would load them with not just aspirin, but also Plavix too, to prepare them for the cath lab. And then I would start them on high intensity statin right away, atorvastatin 80 milligrams. And I would put them on tele to just monitor any kind of malignant arrhythmias that can develop afterwards. So that would be, and if there's pain, I would control the pain. I think giving morphine was in the past kind of the standard, but now we don't do it right away. We first ask if the pain is unbearable, then we utilize it. And then, yeah, that would be my initial approach.
Outstanding. Yeah, I think that the tenets of ACS management are always to give aspirin and atorvastatin. The administration of a P2Y12 inhibitor like clopidogrel is very institution dependent. And the reason it's complicated is because the half-life of the P2Y12 inhibitor is 7 days, which complicates the following possibility. If upon coronary angiography, the anatomy of the patient is such that coronary artery bypass grafting is the only suitable option for the patient, the surgery is delayed. And so if you have an ST elevation MI like this, the idea that you will be able to go to coronary angiography very quickly within the 90 minutes often gives many cardiologists pause and say, let's just see what the anatomy is before we give the Plavix so that we don't commit to not being able to do surgery if needed in a delayed manner. The same is true for non-ST elevation myocardial infarctions, where the anatomy is such that you always have a little bit of a tricky situation with giving the Plavix or not. So our practice pattern here is aspirin, atorvastatin, heparin, either unfractionated, but ideally enoxaparin. And then always, always, always get cardiology involved before you give the P2Y12 inhibitor, because it really influences the patient's need for Plavix. And there's a recent Journal of Hospital Medicine, Things We Do for No Reason, that discusses this topic in detail, which I'll share with everybody in the Academy chat. So yeah, I think you see this and you should empirically treat the patient for sure. And the one other thing I want to impart upon you all is, if you are taking care of a patient who presents quickly with an MI, quickly, i.e. hours afterwards, you're probably going to be able to discharge them the next day. But if you are seeing a delayed case of ACS, this is the patient who is going to be at risk of all the electrical, you already said it, and mechanical. We mentioned LV aneurysm, but others. So this is a patient, when they have an anterior Q wave MI happening right before your eyes, these are the patients who get the VSD and the ischemic mitral regurg and the LV free wall rupture and the AV block and the ventricular arrhythmias. So I would be very, very, very worried about this patient, even if she looked stable now. But we're only 2 aliquots in, so I hand the mic to Maddie to tell us more.
All right, that was just an Outstanding dissection of the EKG. Absolutely amazing job, Tansu. All right, so this is still at the, the outside ED before they even get to the hospital where I'm at. And so she was given aspirin 325 milligrams at that outside ED. And because of those concerning findings on the EKG that you all mentioned, they were transferred to the hospital where I worked. So in the ED where I worked, in terms of her, in the ED, she was still reporting that chest tightness when she arrived to this ED. Vitals, her blood pressure was 140/70. Her heart rate was in the 70s. She was afebrile and she was satting well on room air. I actually, I saw the patient a little bit later on in their course, but the exam that was kind of documented in the ED was that she was actually quite well appearing and her exam was totally normal. So there were clear breath sounds, there were regular heart sounds, the neuroexam was non-focal, there were equal pulses bilaterally, so there were no abnormal findings on physical exam. So I'd love to show you just the second EKG that they got in the hospital when I arrived, just to see if anything stands out to you there.
Tansu, I feel like I should read this and you should give me feedback based on what you did last time. I don't know if I get to reflect on yours. That was awesome. Right. Whenever you're ready, Maddie.
Okay. So this is the EKG now at the second at the current hospital.
Go for it, Tansu. I was just kidding. I'll let you shine again.
Rabih, I don't know if I'm actually doing a good job, but I'm trying. So I think it's more prominent now, the ST elevations. We're seeing it in V1, V2, V3, not so much in V4 or V5. I mean, ST elevations, ST depressions are sometimes as concerning as ST elevations. I'm also scanning for ST depressions here, but I'm just seeing that the ST elevations are more diffuse now in V1, V2, V3. And a poor RV progression still, I'm also seeing that here. That change in the V3, V4, the R wave being taller than S wave is not happening. So the R wave progression is getting poorer and poorer too, I would say. Yeah, I think it's just reconfirming my suspicion for ACS. And what are your thoughts, Rabih?
Yeah, I think your read is absolutely outstanding. And if it's in any doubt how great of a job you're doing, it's just how little I have to add. And I think now that we're getting two EKGs spaced apart, I think we can slow down a little bit. And because oftentimes you just get one EKG and you're analyzing it, but Patty's giving us the privilege of analyzing how EKGs over a period of time. I agree with you. The abnormality here is that this patient has anterior ST elevation. That's the main abnormality here. So, Tansu, in a classic EKG of ACS, in addition to ST elevations, in one area, what might you expect in other areas?
So I would expect to see ST depressions in the reciprocal leads. And I searched for it. I kind of quickly scanned for it, but I didn't appreciate any ST depressions. And then T-wave inversions would be another thing to look for. And yeah, those two, and pathologic Q waves, we already talked about those. But I'm not appreciating any ST depressions. Do you see any?
No, and I think that's the conversation starter. So when you see this EKG, you see this is an anterior STEMI until proven otherwise. But then the thing that would seal the deal is if you have reciprocal depressions. But in this moment, given the fact that the patient is stable, it gives you 30 seconds in real life here, as much as you would like, Tansu, to say, well, wait, okay, patient's stable. I'm going to call cardiology. Let me take a moment to myself to be like, okay, what is the DDX for anterior ST elevations? So, and this is just to prepare you for the reality that you're going to go down the STEMI pathway, but be prepared for it being surprising. So when we touch that button, Tansu, about DDX for anti-ST elevations, what comes to mind?
Definitely Takotsubo cardiomyopathy. So I think an echo will be very helpful here to see if there's regional wall motion abnormalities that's like in the apical pattern, but it can also be mid-ventricular too. So not just apical. So I think echo is definitely necessary. I'm thinking about Takotsubo. I'm not getting like in sepsis, patients can have wall motion abnormalities and EKG changes too, but this patient isn't septic at all, going by the vital signs and how the patient appears. So my differential here is Takotsubo.
Yeah, I think that's spot on. It's the same for me. So whenever you have anterior ST elevations like this, you have to entertain the possibility of Takatsubos. It doesn't change your immediate management, but it forces you to scrutinize the other leads as well. And so the beauty about Takatsubos is that it's one of the EKG patterns in Takatsubos are very, very powerful. You should have no ST depression, reciprocal ST depressions in Takatsubos. A large number of patients with Takatsubos, more so than ACS, will have a prolonged QTC, which this patient does not have. In patients with Takatsubos, the only ST depression they can have is an AVR. So take a look at AVR. What do you think about AVR? Do you think there might be an ST depression or no?
I mean, maybe, and it's kind of like
Yeah.
concave too. So I think the concavity and the slight elevation would favor. Yeah, I think there may be an ST elevation there.
Yeah, for me, I'm looking at it. I'm like, okay, look at AVR. I should have said it more clearly. And so in Takatsubos, you get the only place you get ST depression is in AVR. So
Okay.
I agree with you. I'm looking at AVR and I'm like, I don't think I see an ST depression that's very obvious, but I definitely don't see an ST elevation. And if I use the second QRS in AVR, it looks like there's maybe a sub-millimeter ST depression when compared to the preceding TP segment, but it's not very prominent. So if we're being systematic about this, Tansu, as you were there, this is anterior STEMI until proven otherwise, but the lack of ST depressions should give us pause. And at some point, we should do the echo either before the cath lab or after the cath lab, either way. The other diagnostic possibility, which would also be informed on echo, is a pulmonary embolism, which can cause anterior, i.e., representing the RV ST elevations. And the only reason to reinforce pulmonary embolism is because there are also T-wave inversions in the inferior lead. So if you look at lead 3 and leaky AVF, the T-waves that stood out to you then, they might be compatible with load on the RV. So if you think about V1 and V2 being RV leads and the inferior leads also being RV leads, this might be a pattern related to PE. But I think PE with a heart rate of 70 would be a little bit unusual. Any questions about any of that?
I completely agree. And unless the patient is on a beta blocker, heart rate of 70 in a PE would be very low likelihood. And I didn't hear a beta blocker when Maddie was listing the medications that the patient was taking.
I think the echo will be really, really informative, but let's see what Maddie has in store for us.
All right. Also another amazing dissection of that EKG. So in the ED, the high sensitivity troponin was 13,000. Just did you guys did you want to comment on the elevated troponin in the context of this? If not, I can kind of go forward with what happened next.
Yeah, what do you think, Tatsu?
This is a very high troponin elevation. I mean, it usually starts off as like lower, and then we follow the serial troponins to see if it's uptrending or not to see the delta. But here, I think it's unequally vocally very elevated because it had been a while since the patient was experiencing these symptoms. I'm guessing that's the reason why. So it's very impressive.
Yeah, I completely agree. For later, Tansu, because I know you love cardiology, you should Google the troponin EF product for differentiating between Takatsubos and ACS. And I'll just share really quickly for the sake of time that in Takatsubos, you can get a very high troponin, but it's often in the context of a patient with a very, very, very low EF. So relatively speaking, in patients who have Takatsubos, their troponin is much less so than in patients who have acute coronary syndrome. And so in patients with Takotsubo, they tend to go into heart failure pretty quickly. And so their EF is low and their troponin is relatively low. In stark contrast, when patients go into heart failure, in patients with ACS, they tend not to go into heart failure, and their troponin is really, really high. So their EF is high and their troponin is high. And so the trope EF product is often high. In stark contrast, the classic patient with Takotsubo's has a super depressed EF, and their troponin is underwhelming. So the troponin EF differentiator is really powerful. So here, based on the wellness of the patient, the troponin is really, really high, and the ejection fraction presumably is really, really high. And the trope EF product, therefore, is high, which is an argument, a decent argument against Takotsubo's. And the concept there being that the troponin is disproportionately elevated in ACS compared to the EF. All right, Maddie, what you got in store for us?
All right. So exactly what your concern was. So at this point, with those EKG changes, the elevated troponin, the history, there was concern for ACS. And so the cath lab was activated. In terms of kind of the timing of the treatment, heparin was actually not started before because she went directly to the cath lab. And in the cath lab, the findings of the coronary angiography were that she had a subacute distal LAD occlusion with left-to-left collaterals in the apical LAD. And on review of the cardiologist kind of afterwards, they found that the apical LAD had minor flow, but was atretic. And they actually attempted PCI at the distal LAD, but were unfortunately unable to pass the wire through. So unfortunately, it was not revascularized. So to kind of summarize, apical distal LAD, but they were not able to pass the wire through to do a stent. And then in the cath lab, she was given unfractionated heparin and she was loaded with 180 of ticagrelor. And I have the echo next, but I'll kind of pause there to hear any reflections you have.
I'd love to hear it, Tansu. Maybe I can just ask Maddie, do you happen to remember if she had coronary artery disease elsewhere, or did she just have a focal total occlusion?
I believe it was just that focal occlusion. There was not other significant.
Yeah.
Yeah.
I wouldn't be surprised if that's the case, and we can talk about that as a small teaching point. But yeah, Tansu, what do you think?
So even though the patient didn't seem to have any exertion, like symptoms on exertion before this presentation, from the story that we got, she sounded like a perfectly healthy person with no symptoms at baseline with exertion. But she has many comorbidities that could predispose someone to have ACS with hypertension, hyperlipidemia, and she's on appropriate medications too. She was on lisinopril for hypertension and she was on a statin for hyperlipidemia, but still ACS can develop. So just because the patient is receiving treatment doesn't mean that her risk factors are optimally controlled. And it's very unfortunate. And what I heard from Maddie is that there's subacute distal LAD occlusion with collateral. So the fact that there are collateral formation just shows me the chronicity of this of her coronary artery disease, and how long has this been going for that to allow the formation of collaterals. So those are the first thoughts that come to my mind.
Yeah, I mean, you're saying it so eloquently. Yeah, you started with ACS. You were really worried about that. You got your EKG, you got your troponin, you were even more worried about that. And I think now you just essentially confirmed it. But you're picking up on some really important points, which is that this has been going on for some time. I don't know exactly, and I'll have to look it up later, about how long it takes to form collaterals, but it certainly isn't minutes to hours. And so you wonder if she yeah, for a moment you might pause and say, is this what's causing the syndrome now? But I think with the height of the troponin, you know something happened to her now. Yeah, and I think we're also learning, Tansu, how when a fibrinous plaque evolves over time, it becomes more fibrous, hard, and hard to remove. So unfortunately, this patient will really not get treatment for this event, and all we can do is secondary prevention, which is really, really tragic. And so I think, as we said, we have to maintain vigilance for any complications that this patient has because of an unrevascularized MI. But I think one really important nuance that you and I can try to tease out together is how to reconcile the fact that she didn't have any symptoms of CAD, right? And she didn't have any other findings on her RCA, left circumflex, proximal LAD. So how do you square away those two things?
I mean, it's definitely very interesting. The fact that she was asymptomatic, I think ACS or coronary artery disease, CAD, can present in many different ways, and especially in some populations like women and elderly people, they may not have any chest pain. They can present with diaphoresis and not really any chest pain. So this patient being a female patient and the age is relatively on the older side, um, I think she just fits into that category of patients who don't have the typical ACS symptoms, don't have a typical presentation. And what was your second question?
Oh my God, I forgot it, but you answered it anyway. Yeah, you're absolutely right. So this is such a great opportunity for us to take a moment to emphasize the why behind your statement about the atypical presentation of ACS. And I think to understand um, classic CAD symptoms of exertional dyspnea or shortness of breath, you really have to emphasize that what we're talking about in that situation when patients have angina is not atherosclerotic coronary artery disease, but actually it's a small category of atherosclerotic coronary artery disease, better termed flow limiting CAD. So remember that atherosclerosis does not begin in the lumen of the blood vessel. It begins in the wall, depositing macrophages full of lipid material in the wall. And as it enlarges and gets bigger and bigger and bigger, it starts to erode into the lumen. And it also forms a really thick fibrous cap that limits the flow, ultimately resulting in flow limiting coronary artery disease. And so many patients first develop disease in the wall, and only upon a lot of time, often years to decades, do they get flow limiting coronary artery disease. So when we say that atherosclerosis develops in 60 or 70-year-olds, we're not being precise. We're saying that the disease has probably been there for 20 years. It's now evolved into flow limiting disease. But that's one point. The other point to tell you, Tansu, is to make an educated guess about this question. If you take all patients with STEMI, compare them to non-STEMI, what percentage of patients do you think with a STEMI have had a previous MI? In other words, what I'm trying to get at is, what is the probability that somebody's first MI will be a STEMI compared to their second MI? What's your sense on that? What's your gut sense?
I think the chances that the first event will be an NSTEMI is higher than the first event being a STEMI. Because it can present itself as not a totally occlusive and ischemic way before it causes the infarct in the form of STEMI.
Yeah. That was exactly how I used to think about it until I learned that the opposite is actually true. And it's a very fascinating concept, Tansu. The idea being that if you have no flow limiting CAD and you just have atherosclerotic plaque in the wall, those plaques do not have a fibrous cap, and the patient has no coronary artery disease anywhere else. Those atherosclerotic lesions without a fibrous cap are way more vulnerable to fully rupture and cause complete total occlusion. So if you take all patients with STEMI, about half of them have never had a prior MI. That's in contrast to the typical ratio of STEMI and non-STEMI. So the typical ratio is 9-1. That NSTEMI is 9 times more common than a STEMI. But if you take first-time presenters, the ratio is much more skewed towards a STEMI. And the reasons are twofold. One, patients with recent without flow-limiting coronary artery disease have very vulnerable atherosclerotic disease that has not yet had the protection of a fibrous cap that limits how much explosion into the lumen happens. And the second thing you already said, collaterals. When you have had long-standing flow-limiting CAD, you form collaterals. And the collaterals allow perfusion around total occlusions. So even if you're unlucky enough to get a total occlusion, if you've had flow-limiting disease for a while, the collaterals protect you from infarcting your LV. So it's so counterintuitive. If you talk to a patient who has severe ACS-like pain and they don't have a history suggestive of CAD, there's two completely polar opposite possibilities. One is they don't have CAD and they don't have ACS, and it's not coronary disease. The other possibility is they had microscopic atherosclerosis in the wall. They have no collaterals, no symptoms whatsoever, and they're the unlucky few who, boom, have a STEMI. Completely polar opposite presentations, but it's actually really easy in real life because their EKG either will show nothing, suggesting the benign possibility, or will show a STEMI, which will not be hard to miss. So you will see many of these patients in the future where they're like, I'm a perfectly functional human being. I have no idea why I have this chest pain. And in 99% of them, you'll see a normal EKG. You'll be like, you're fine. In 1% of them, you will see this, where they have atherosclerosis of the wall and they present with a STEMI. It's a really, really difficult thing, which pushes you to never, ever, ever not get an EKG in a patient like that. Sometimes we say, oh, you have no risk factors. Don't worry about it. It's fine. It's just GERD. And then you look at the EKG and you'll see a STEMI. So it's a hard concept to teach because it's so counterintuitive to the main narrative about STEMI and non-STEMI. And honestly, Tansu, up until a year ago, I didn't appreciate this issue. So I wanted to use this as an opportunity to see what questions you have so everybody is clear on it.
I think it makes sense that when the plaque doesn't have a fibrous cap and it's not mature yet, the first presentation would be STEMI instead of NSTEMI. I was unsure about my answer. That also brings to mind a discussion that we had in CCU. One of our attendings said, even though coronary catheterization angiography is seen as the gold standard diagnostic method to diagnose coronary artery disease, coronary artery disease doesn't actually develop in the lumen of the blood vessels first. It develops in the walls of the vessel, just like how you described. So getting a coronary CT angiography is better because that also shows what's in the walls of the coronary blood vessels, coronary arteries.
Such an outstanding point. I couldn't agree more. It really reinforces yet another perspective on this important concept. Awesome. All righty, Maddie, what do you have left for us?
All right. So in terms of kind of, I guess, well, she got an echo basically after the cath, and that showed a normal ejection fraction of 67%. It showed apical akinesis and some septal hypokinesis. There was no aneurysm or effusion. To talk about some of the additional tests that we sent, so to kind of assess risk factors, sent an A1C and a lipid panel. Her A1C was 5.1. Her lipid panel, the LDL was 80. And ultimately she was, started on dual antiplatelet therapy with aspirin and ticagrelor. Her atorvastatin was increased to the 80 milligrams. And I can share there's kind of an interesting conversation of the value of a beta blocker in kind of post-ACS care. She was ultimately kind of when monitoring her on tele for the next few days, she had frequent PVCs. As kind of a team, we made the decision to start her on metoprolol succinate 50 milligrams due to those frequent PVCs. And so ultimately, kind of the final diagnosis in this case was a late presentation of the transmural apical MI, as you all highlighted. And I kind of checked her chart. And so I saw her last week or so. She's already had a a follow-up appointment, and she is feeling very well. She's like walking daily, she's feeling good, and plan for her to get a repeat echo in kind of the next week to assess for any thrombus formation or any kind of, yeah, any like complications, but she's overall feeling very well. Um, and yeah, I can chat a little bit, but there was an interesting, like currently in the guidelines, beta blockers are still part of kind of standard care for post ACS, but there was actually, I can share this, but there was a really interesting kind of commentary in NEGM where it's kind of a controversial topic about beta blockers. Like some people feel that it's not, there's basically been recent evidence that for patients with normal LV function who have been revascularized, beta blockers don't necessarily improve mortality. But in this patient with the frequent PVCs and the fact that she wasn't revascularized, the decision was made to put her on a beta blocker. So yeah, that is the case. I will pause there to hear any reflections you'll have.
I just really wanted to thank you, Maddie, for bringing this feels like bread and butter, but it's so stressful and difficult to manage in real life, and really allowed us to make a lot of teaching on something that many people will likely see over and over again. So thank you so much. I really, really appreciate it. Tansu, how are you feeling?
I'm feeling great. I loved your case, Maddie. It's definitely bread and butter, but it's a case that we oftentimes see in the hospital, in the emergency room, and even in the inpatient setting when we are caring for patients' other chronic conditions. So it was definitely a great case. Lots of learning for me, especially the point about Troponin EF product, something that I did not know before. So I'll be doing some more reading on this after this session.
Yeah, I mean, for me, Tanto, seeing how I think you've learned a lot in intern year, but I think learning the practicalities of how to incorporate that knowledge and to use it to your advantage is incredible. I think your EKG reading skills will live on for a long, long, long time. That was an absolutely great read of the EKG, and then also just the fact that you were able to learn something relatively new on the fly, the distinction between the first presentation of STEMI and non-STEMI, to absorb that and to incorporate that with what you had just learned about CTA versus cath is just awesome. So it's always a pleasure, always a treat. It's great to see after a long time of not discussing with you just how much you've learned and all that blood, sweat, and tears that have come out in intern year. They're definitely doing a lot for you. I can tell you that for sure. So thank you for a wonderful hour. We get Julia to recap all the learning. So I'll hand the mic to you, Julia.
What a journey. Tansu, it was so nice to hear you voice back on the case discussion seat. So hopefully have the pleasure soon again. I'm so impressed by your EKG reading skills. So I tried to summarize the key learning points for today because there were so many, and I feel so many useful ones that many of us will encounter during residency. So we had a 67-year-old female who presented in an acute setting of like substernal chest pain. So with acute onset of chest pain, we have to rule out the most morbid causes of chest pain in our patients. We have the very useful 4+2+2 mnemonic that reminds us on the most morbid causes, including the 4 cardiac ones, ACS, tamponade, aortic dissection, and Takotsubo cardiomyopathy, 2 lung causes being pneumothorax, thorax, and PE, and lastly, the esophageal causes being rupture and impaction. I very much liked that Rabih reminded us on the pillars of ACS. So really thinking about what does lead us and a patient to send them to the cath lab. So first, if we have a very pertinent story, especially if we have any signs of prior CAD, if there is signs of ischemia on EKG, also an elevation, or to be more specific, a dynamic and troponin in our labs. Of course, any focal wall motion abnormalities that can lead us to be suspicious for ACS. And lastly, to really think about other causes that have to be ruled out. One great reminder was that if we have chest pain, at rest, that can be a sign for ACS, but it's also very interesting to think about the story. So the prior story of CAD. So a hint would be chest pain on exertion. Of course, if you have chest pain at rest, you would not assess that. So you should really ask that if whether there have been any symptoms before the initial presentation. Also, if we have an ST elevation, myocardial infarction, the most important medication we have to keep in mind and always give to the patient are ASS, atorvastatin, and enoxaparin. Before we give a P2Y12 inhibitor, we should really consult cardiology because it can delay any surgery, so bypass operation, for example, because of its long half-life. Then I'm still impressed with Tansu's EKG skills. So we had two nice teaching points here, which I thought were first Q waves and poor progression can be a hint for the time course of any ischemia. So that could hint to an old anterior myocardial infarction if it presents in the anterior leads. Also, if we see ST elevation, that could be one of three causes. Either it can be a hint to the myocardial infarction being just hours or days before. It could also be a repolarization issue, or lastly, as a sign for LV aneurysm. In our patient, we had a beautiful twist by Tansu's observation that we don't see as reciprocal ST depressions. So that let us pause for a second and think about differentials for anterior ST elevations, mostly thinking about Takotsubo cardiomyopathy. Interestingly, Takotsubo cardiomyopathy does not have ST depressions except in AVR. However, the most beautiful learning point for today I felt was Rabih's Trop times EF product. It can help us distinguish ACS from Takotsubo, where in ACS we would have a disproportionately high troponin and high EF, leading to a high product, whereas in Takotsubo we would have a low EF and just mildly elevated troponin, leading to a low product. Because the product was high in our case, it was an argument against Takotsubo. Lastly, I loved the pathophysiology recap on how arteriosclerosis actually develop. So we have to remind ourselves that it starts in the vessels. That means that it does take a while until a flow limiting CAD develops. Most of the STEMIs we see are non-end STEMIs because there have been like a long time where collaterals can form, and also perfusion is still going on behind the occlusion. Whereas if you're an unlucky presenter with no prior episodes, that can either be like a benign course or in rare cases a STEMI, because there has not been any time for the like plaque to develop a fibrinous cap that protects them from rupture. So a lot of learning in this like bread and butter case. So thank you so much for Mehdi presenting this case, and everybody in the chat discussing it. And yeah, hopefully see you tomorrow.
Oh my gosh, you absorb everything and then regurgitate it with such clarity. I think for everybody watching, you should also just pay attention to how slow and deliberate Julia is. I think a lot of the timing of the teaching points at the end can feel very pressured. You feel like you got to move quickly and like rush through it. And I think resisting that urge and taking up space and teaching calmly and clearly as you did, Julia, is awesome. It's not easy to do. All right, guys, have a wonderful rest of your day. Thank you for an awesome hour. See you later.